let me take you way, 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 way back, right? So when did you first think you were going to be a pediatrician?
So when I finished my third year and thinking the whole time I wanted to do OBGYN.
Okay.
And then had not the best experience.
Oh.
And looked back on kind of my life and what things I had done and participated in and realized, I think peds would be a good fit. My rotation was just one floor in a bigger hospital.
Yeah.
And so I'm not sure when I did my rotation, I got the full peds experience.
So that was your third year?
That was my third year.
Okay.
Yeah.
Prior to then, any exposure to pediatricians or anything like that that influenced you?
No one in my family was a physician, and I went to a family practice doctor my whole life, and yeah. So
what was the magic? What was the hook?
I think because when I looked back, I always was like, wow, I'm the one that kind of wanted to just jump and fix everybody's little boo-boos, like get the Band-Aids and the spray and clean them up. And
first aid person, that's interesting. So then when you did your M3 rotation, what was it about that experience that said, all right, this is it?
I think because I really liked internal medicine and the academic nature of it, but I didn't love adults. Yeah. And all their problem lists and their medication lists, and I think like that was the next best fit. It was like internal medicine but peds.
And so did you ever think about being a specialist?
I did. I really thought I might do hem-onc.
Okay.
And I think at the end of the day, which is so funny now, right, is I thought, wow, 3 years from now, I'm gonna have to do probably research, I'm gonna have to live in a specific area and work for a children's hospital, and I don't know if I wanna do all those things. And I just laugh, because here I am at a children's hospital and I do research. So.
Right. So what made you not do hem-onc? I'm curious.
I think because I wasn't sure that at the end of the day I was gonna be in the exact kind of spot that I wanted to be.
Okay.
And I thought, I don't know if I can commit to 3 more years of training, 3 more years of not being paid well, 3 more years of bad hours. Sure. But yeah.
So then you became a general pediatrician, but you stayed connected to the academics. What was that about?
So I took over for somebody at a Chip Wadsworth who had a resident working under her. Okay. And since it was like mid-year and everything, and she was gonna be a senior resident, they said, hey, would you, take her on? I was like, sure, no worries. Yeah. I'm used to teaching, great. Yeah. And yeah, I didn't think anything of it.
So how did that turn into this, like what you have now?
So I think it was because I enjoyed having the residents, and I just kept re-signing up for having a resident working with me in clinic, and then I had medical students working with me, and then somebody nominated me for the teaching award. And then I think when Dr. Specht, who was originally in the residency program, was talking about cutting down our hours and retiring, they actually asked me to take on the role.
Very cool. What an honor.
Yeah, it was great.
She was pretty awesome.
Yeah, it was pretty great. So, and I got to work with her and overlap with her for a couple years, which was great.
Tell us, what do you do today? Tell us your title, and then tell us what you actually do.
So I am an associate program director for the residency program, which means that, but I'm on the ambulatory side. I'm a general pediatrician. Okay. And so I kind of help with the more ambulatory aspects of the residency program.
Okay. When you say ambulatory, what does that mean?
Yeah, outpatient.
Okay.
The continuity clinic for the residents, run some of their other rotations like the well newborn rotation, the parenting elective, help a lot with recruitment. Yep. And then on the side, I do my own kind of not on the side, but
Yeah.
I do some research nationally with the.
We'll get to that in a second. Tell me about the parenting elective. Is that a national thing that everybody does, or is that unique to children's?
So such a good question, because this is something that I started a few years back, but a lot of programs have been adopting it. It is an elective focused really on kind of the parenting issues of children and infants that doesn't get covered a lot in kind of the traditional residency curriculum. So, a lot of people think of it of, oh, I had a baby and I'm going to return to work on this elective. And that's very valid, but we also have a lot of non-parents that take the elective and can really focus on the things that they are interested and want to learn.
So clarify that for me. So you said, so I've just had a baby, I'm going to take this elective. Does that mean that was it designed for returning moms?
It wasn't actually designed that way, but it is a way that a lot of people, trainees in particular, can return to work and ease their transition back to work with still basically getting paid.
So they also have, so they're a new parent, but they're getting formal training on how to be a parent and be a teacher to parents.
Yes.
Very interesting. What's the feedback been like?
The feedback is just great, even particularly from the non-parents who feel like they have had the opportunity to sit and read about things like discipline or feeding or stuff that they're not maybe as familiar with, but get asked about all the time by parents and just don't know how to answer.
Yeah, no, that's really, really cool. You and I have had the conversation about the stress of residency at baseline. So much so, I think, for me, I think of residency modeling like a disease state.
Yes.
Right? It's temporary. You're kind of stronger at the end. You're better at the end if you make it through. And most make it through, obviously, but it is very stressful. And so talk a little bit about how, because you mentioned you were thinking and leaning towards OB. You ended up in peds. Tell me what your sense is about the stress of residency education, the 36 months, and the impact of pregnancy and what that would mean during residency.
So it is hard to get everything that's required in 36 months. And you get vacation time, of course, but it's limited. Your schedule does get easier as you progress from year to year, but then you have a baby on top of a difficult work schedule in terms of particularly hours and intensity of work. And I would say, unfortunately, when you find out that you're expecting, you often have to adjust your schedule with the goal to have kind of some time off afterward, which means you often kind of have to stack some of your harder electives in the beginning while you're pregnant, and then stack some of them after when you're dealing with an infant at home. So it's particularly challenging.
Let me reflect on what I just heard you say. So you're saying someone becomes aware that they're expecting. They now have to take, intentionally put some of the more challenging rotations on while they're early pregnant. So they can be dealing with morning sickness and all of the other side effects of, making a human being. And then they come back during the reentry phase where they're also at risk for, postpartum things that can happen to you. And they also have to put some challenging rotations there too. And so the parenting elective really kind of softens that landing, ideally.
I think the biggest thing for parents right now is that it's the amount of time off that you can take without extending training and with pay. And I think that's one of the things that's just so hard, is that many people could take more time off, and we would encourage them to take more time off, but they just know it's going to knock their timeline, and many of them are not in a financial position to take all that time off. So yes, in a way, we can kind of get them back to work at least and be paid, so they don't have to extend their training, and they're getting paid. So it is ideal for new parents, but there's value for non-parents as well.
So what do you think is different? Let's talk a little bit about medical education. What's different today than 20 years ago, right? I'll just say when I was in training, and a lot of my colleagues were pregnant during residency, and I was a chief resident, so I remember doing some of that scheduling and rescheduling. It felt like everybody did okay. Now, I'm completely oblivious to I'll just say what happens in the girls' locker room, right? That conversation. So it seemed like everyone made it. Why do we need something like that these days?
I think the intensity of the training now, the kids that are in the hospital are just sicker.
Yeah.
They're more complicated. The system is more complicated. You have electronic health records. Everything just seems to be harder.
You mean they have a long problem list?
Yeah.
And medication list?
It's
like internal medicine,
I know,
my gosh.
But they have to reconcile things and do notes they didn't have to do before.
Right, it's a different world.
It's just
It's a very different world.
And I trained about 20 years ago too, so it's just hard.
Yeah, I think one of the least appreciated developments in healthcare is the EHR. Mm-hmm. Right? Lots of upsides, right? Tons and tons of upsides. And if someone said, we're going to get rid of the EHR, we're going back to paper in 2025, I would lose my mind, right? Tons of upsides. But it is a game changer. And I think it's added an additional layer of stress to how you do what you do. And I think it also, if you can speak to, I think it's created more space between us. As human beings, as doctors and nurses and respiratory therapists and social workers and so on. How do you think that's affected how we do what we do? Has it added to the stress?
I think it's added.
How do we address that?
If everybody could figure that out, right? But I think it's because people are now, focused in front of a computer as opposed to face-to-face talking, right? So the messaging, particularly between people, is just through either the phone or through the computer, and it's not like you have to go up and talk to somebody, which we used to all have to do, and we used to have to go over to the bedside and say, hey, do you still have that chart? Can I look at that chart? Right. Hey, how's that patient doing? It's just so interesting, and I know that, I even have a hard time just outpatient. I'm a little bit more fortunate. I can kind of have my laptop with me and I can still kind of look at patients and things, but it is still a barrier even outpatient, but in the inpatient I think it's even worse.
It's madness, yeah. There's promise on the horizon with artificial intelligence, and some of the technology I think will help with that. But it's almost like we have to fight to keep the human touch, right, in that interaction, and reduce the space between us, and use the technology, right? So it has made it very difficult. Talk a little bit about how your role in medical education has changed.
I think the biggest thing is just seeing that the burnout in the residents over the years. I've now been in medical education about 10 years, and I do think the stress, and I think, a lot of it also comes down to all the extra things that everybody is required to do outside of your main job. And so every time Epic has an upgrade, you have to do training. And there's mandatory training and modules and quality things. And those are all good things, but when do you fit everything in? And, that's certainly with us, and it's also on the residents. And I think that's where a lot of burnout comes from. And so I think we have just been more obviously aware and focused on that. We, as a program, are part of one of the organizations that started about the Burnout and Resilience Consortium. And I've been one of the site leads for that program for a couple years now. And I think the main focus of that organization was, well, we got to figure out the problem first, and now we're working towards trying to address things. But unfortunately, even though there have been very good interventions, and I think people have thought very hard about this, I don't know if we're making a lot of headway. Yeah, it's hard to tell what is the thing that helps. And like, as you said, maybe there isn't something that helps. It's got to be, I think we were all burned out before. Mm-hmm. We just weren't as aware. We didn't talk about it as much.
But I think we're also in a different era, right? I think the things that made me and you maybe exhausted back in the day, right, 20 years ago, was the clinical burden.
Yes.
Today, the clinical burden is still there, and in many instances, it's worse. What I don't think we had as much was the administrative burden.
For sure.
I mean, if you talk to our documentation folks here in the hospital, our compliance, regulatory and compliance group, I mean, the amount of documentation that's required to say that a hospital is a legitimate place has just skyrocketed over the years. And the same amount of documentation or similar, spike in documentation has happened on the clinical side as well. And I think, so, when I think about folks who aren't physicians and who aren't providers, who aren't directly involved in patient care, what do you think the message can be to them to help them understand when people who are delivering direct patient care saying they're feeling burned out, they're feeling the weight, what's your message to them so they can understand what needs to be done to get a better understanding of it?
Oh gosh, please make things simpler for us.
Simple.
Let us focus on patient care and relationships if we can.
Yeah.
Can you somehow give us the time to, when we have these other administrative things to do that aren't jammed into the middle of all of our other working hours?
So really think about that administrative burden. And, I think so I'm one of those people who I would say I heart Epic, right? I actually do. I love Epic. Having said that, what I struggle with sometimes is how we would add a gizmo gadget, some shiny thing to Epic, but we wouldn't take anything away. Right? And I think part of the lesson for our coders and builders and the people who love making Epic even greater is if it adds to the administrative burden, then it's not a win. Yeah, great way to put that. So your research, tell me a little bit more about how you went into the research space. How did that happen?
Yeah, I think I was fortunate that when I first joined medical education here, I got to attend some of the national conferences, one of them being the Association of Pediatric Program Directors. And there's a little over 200 pediatric residency programs, and that organization, pretty much everybody is in it. And it's just a wonderful place. And I think through that participation and getting to meet people from all over, and the talking and collaboration, and the first kind of interest group that I joined there was the research and scholarship learning community, and then met my people.
Yeah, it's fascinating to think that you looked at HEMONC and one of the parts of it was all the research, and now you're doing all the research, but it's different, right? It's different. Yeah, how is it different?
It's medical education-based research, which is definitely different, certainly, than bench research, which I dabbled in a little bit in undergrad. And it's different, I would say, probably than a lot of the hematology-oncology research, because those are very protocol-driven. This is more, it's harder in some ways because it's harder to quantify things, I would say. You're dealing a lot with perceptions and attitudes and things, which is very survey-based.
What are some of the burning medical education research questions out there?
I think, how do we make burnout better?
Yeah.
How do we support our trainees better? How do we help them when they want to have babies and they want to breastfeed?
That's a pretty fundamental question.
Yeah, but
Yeah, interesting.
we do such a poor job as a children's hospital in general.
So let me kind of poke at the elephant in the room there, though, right? Because part of it is our culture, right? As doctors, we're helpers. We don't ask for help, right? And so I certainly think the healthcare system can do things differently. But I also think as a culture, one of the things that I used to hear, and I said myself when I was in training, I remember one of my chief residents would leave and he would say, remember, Mike, call me if you need me if you call me. And as he walked away, he would say, but remember, calling is a sign of weakness.
Oh, gosh.
Right?
Well, thanks.
Right, so it's tongue-in-cheek, but you can see it, how it plays out in our culture, right? And so our generation, I think, didn't ask for help because we thought that would mean you're less than a doctor, right?
Yeah, or you're not competent.
I feel like this generation definitely will ask for help and will give you, deduct points if you're not helping enough, right? Yeah. And so the system really does need to change, but I think the culture needs to change to recognize that asking for help is not a sign of weakness. It actually is a sign of maturity. And so how do we, when you think about from a research standpoint, we have to do more qualitative research. That's, again, another elephant in the room is as physicians, we're trained that qualitative research, soft science, right? It's not real, et cetera, right? And so that's obviously not accurate at all. And so leaning more towards mixed methods and so on. So what are your research questions that you're asking?
So right now I just finished up a mixed methods study around parenting electives and more around the impact of them from the resident perspective. How are they using them? What kind of value are they finding out of them? And also helping with a book chapter around supporting trainees who choose to have babies and are lactating, and asking a little bit more about burnout. So I've got a study that is just launching that's going through the AAP about burnout from not just in residency, but how you go from residency to the next step, to fellowship or to an early career pediatrician. And are those factors different? And do you kind of have the same level of burnout as you do as your resident? Are you somebody who tends to be very stressed and burned out in general or not? And I don't think anybody's really tried to follow an individual. I think we are trying to test the hypothesis that maybe there are people that tend to be more the Eeyores, and they tend to be the same people who are burned out in residency or the same people that are burned out as they take their next step versus not. And maybe we'll be surprised. Yeah. I don't know.
Well, it is an interesting concept because I remember talking to someone who looked at physical activity and exercise during residency. And what they found is that there's less exercise and physical activity during your training. And what you tell your patients is also incomplete or inaccurate as far as what's recommended, what we should be telling people. And one of the weaknesses of this study that we talked about was we didn't know if they were physically active before residency. Because I don't think that being a resident makes you more physically active. Right. So wherever you are, you're probably going to lose a little bit during the grind of the 3 years. But that's a great study design because I think you can blame the training, but it's also kind of what you're made of too, right? So, yeah, I heard a pastor years ago said, "Remember that the same sun that melts butter hardens clay," right? And the point is, it's what you're made of. Yeah, it's certainly it may be the environment too, but
yeah, I definitely think it's contributing, but it's kind of like how do you deal with adversity, right? And obviously we are all in a kind of a higher stress field, and not only training, but once you become, an attending or, and the responsibility, I think, that you feel, right, is different. That level of responsibility definitely keeps increasing, so.
So where do you see the future of medical education? I'll ask you really specifically. What's the biggest threat to us having a system that creates practice-ready pediatricians?
I think the biggest threat is really the input in terms of the people wanting to choose medicine and choosing pediatrics in particular.
Okay.
It's hard, and when you come out after having a lot of debt from medical school, and then you kind of carry that debt for several more years in training, and you're not paying anything on it, and you're not contributing to your own kind of future financial state, you go, wow, there's easier ways to make money than this.
That's true.
And so I think, it's really it's getting the people, one, in. That's, I think, the biggest thing. And then I think once we get them in, how do we keep them in and retain them and make sure that they don't also say, wow, this is not worth it. There's got to be enough, hopefully, good parts and benefits of the job to keep them.
Couldn't agree more. So I'm a second year undifferentiated pluripotential medical student, right? And I'm going to ask you, Dr. Ben-Zion, so what brings you joy in your work? Why should I do what you do?
Because I love seeing the kids. I literally, on my way walking over to this interview, ran into one of my patients who was here getting a checkup on her heart defect that she had to get repaired, and just the smile on her face when they run into me outside of work. I know, not work, I'm working, but I'm not in my office. And the cards and the things that I get, they're just so happy, typically, and healthy. And I just feel like, I've been doing this long enough now that I've been able to see maybe some impact that I do make. And that is the thing that just keeps me going every day, that I'm going to impact their life, hopefully in a positive manner.
Not everybody can say that. Yeah, we're privileged to be in a high impact area every day. So it's pretty cool. Well, thanks for your time.
Thank you.
Really appreciate it. This is fun.